Welcome to EuroPCR 2021. My name is Wolfgang Rothbauer, head of the Department of Cardiology at the Ulm University, Germany. I'm happy to have the opportunity today to look with two real experts and pioneers on the percutaneous tricuspid valve treatment, namely Professor Ralf Bardeleben from Mainz, Germany, and Professor Georg Nickenig from Bonn, Germany, into distinct treatment options of tricuspid regurgitation with the Edwards portfolio. In the next 15 minutes, the three of us will try to give an overview of three distinct devices for targeted treatment of tricuspid regurgitation. Especially, we will have an overview how these devices look like, how they work, when to use them, and what their clinical outcome data is so far. Much of the clinical results will be or were already shown in late-breaking trials of the EuroPCR 2021. Here you see the broad Edwards portfolio on interventional treatment of tricuspid regurgitation. From a historical perspective, it started with the Cardioband, initially for mitral valve repair in 2015, followed by its systematic use in 2018 on tricuspid regurgitation. In 2019, the Pascal repair system was introduced for leaflet repair, first on the mitral valve, and in 2020 for repair on tricuspid valve pathologies. Finally, and we will discuss that today, there are future developments, and such as the complete valve replacement of the tricuspid valve with the EVOQUE system, and we will focus on that too. What you see here is the Pascal platform, and now welcome again, Georg. Would you mind to explain to us the Pascal system, the main features, and what is the difference to the ACE that is shown on the right?
Sure, I will. Thank you very much for the introduction and for involving me. What you see here is a Pascal device, the two different forms, if you will, the classical form, the classic, and the ACE device. And that is true for both. It comes via a transvenous puncture, via a steerable guide into the mitral, or here in the tricuspid space. And then you add actually two additional components, which makes the system extremely flexible. You can steer it in the right atrium in all three dimensions, which is very, very important, which is not explicitly shown here on that slide. Why is that important? Because trajectory and also distance to the annulus is extremely important to be very variable with your system, because sometimes you are very prone to the septal side or to the anterior side of the valve, and you can get around this with this device very easily. As I pointed out, it's a nitinol design. Both have a span of 25 millimeters, and the ACE device, which I think most of us use predominantly in the tricuspid, has a width between 4 and 6 millimeters of their clasp. So it's a pretty large device, what we need in the tricuspid space. It has the possibility to use the clasps independently, which means you could, for example, start with the anterolateral leaflet, if you will, and could then steer the system towards the septal leaflet and clasp the second leaflet then with the second clasps, which enables to deal with larger gaps. There is a central spacer in between, is there in order to reduce the residual central jet of the regurgitation. And then you have the possibility to elongate the whole system so that you can exclude entanglement into chordae. And I think that is, in a nutshell, these are the most important features of the device.
Okay. Yeah, I think this was very helpful to the auditorium to explain the main features, especially the flexibility and the non-entangling in the tricuspid apparatus. Ralf, it's now up to you. I think we will see there some data from your group Could you explain them? What are the first clinical results we've seen so far, and what's the fascinating point about them?
I think with the introduction here of the Pascal experience, and especially also later what we will see with the ACE, we have a very performance system, as you can see on the left-hand side. So the first aim of a tricuspid valve repair system is, of course, to treat the tricuspid regurgitation. And we can nicely see from the color change here on the left-hand side on 28 patients from the compassionate use, how the TR5+, which is torrential, and 4+, which is massive, in the new Becky-Hahn grading scheme, really changes to green colors. And what is nice in this depiction is that you can see what kind of patients stay in the same group and what kind of patients really leave the group to either a better or to a worse graduation. And you can see that most of the patients here change to better graduations in the first 30 days. And you can see that up to 22 months, the results of 30 days are very stable and maintained. And this is actually an experience that we have from a lot of transcatheter systems. So in the beginning, we were unsure about this treatment stability on the reduction of the regurgitation, but we can say now that in both an MR and in TR, 30-day results are very predictive of 1 year and 2 year results. On the right-hand side, you can see that the New York Heart Association class change is even more pronounced. We can see that we achieve a majority of patients which reaches 90% into New York Heart Association class 1 or 2. So with a possible, because this is of course a single arm compassionate use treatment with a potential part of a small placebo effect, we see that this is very, very helpful, both clinically and in the regurgitation level.
Terrific. So we will even see more data. Maybe, Ralph, you continue on that. And what's the major difference now when you look in a real life world experience? What do you think about these results combined from 4 different sites?
As we see, TR severity change is even more pronounced. What we also see is that there's a very, very small number maintaining torrential or massive TR, which is here only 1%. These are high volume centers. So this shows, of course, that it's very important to have high volume centers in order to be effective. And what we see here is that a very good reduction is done in a post-procedural and follow-up situation in 83 to 90%. We also see that post-procedural results in the cath lab can sometimes overestimate a little bit the reduction, but follow-up is very stable and also very beneficial. So 83% is about the range we had in early experience mitral. And we have to remember that our transcatheter tricuspid experience is of course less than our mitral experience. New York Heart Association class was changed similarly. Perhaps the centers treated a different kind of patients in the commercial arena. We can see that the New York Heart Association classes are perhaps a little bit more realistic than what we have seen in the early compassionate use that are highly selected. Class PR is a US trial so far, so Europe is not involved in comparison to compassionate use and to the early commercial experience. But we can see that actually we see the results reproduced, which is very beneficial. So the US interventional cardiologists have a lower number of roll-in experience in tricuspid treatment. And even with the smaller number of roll-ins, we can see that 78% compares favorable to 83%, so that we have a very high reproducibility actually of the results as we see here. So these results again are comparable to the compassionate use experience gained in Europe, here in the US.
Great. So that's very fascinating. So I think we move on to the next topic. One might even think we don't need other devices, but Georg, I would like you to explain to us the Cardioband system, maybe within 30 seconds. What are the main features that are helpful to work, especially on the tricuspid valve?
So first of all, the leading pathology usually of tricuspid regurgitation is annular dilation, and therefore it is a nice idea to use a device which can reduce annular anatomy, and that's what the Cardioband does. It comes from the anterior side and then you implant it from the lateral to the posterior side with the help usually of 15 to 17 anchors, and there is a wire in between which you can foreshorten, and by this you can shrink, if you will, the annulus by a couple of centimeters, and by this reduce septorolateral diameter, and ultimately hopefully also reduce tricuspid regurgitation.
Okay, and do we have clinical data on there?
Yes, we do. The first data which came from the TRI-REPAIR study, and they are comparable to the data which we see here. This is a TRIPENT study. It's a commercial study after CE mark approval in Europe, multi-center study, core lab adjudicated, and has a clinical event committee. And what you can see here, baseline, it's the second column on the left. You can see that most of the patients had torrential, massive, or severe tricuspid regurgitation. And then if you look at discharge, and even after 30 days, which is the fourth column from the left, you can see that roughly 70% of the patients presented with TR moderate or even less, which is also an encouraging result. And again, this is core lab adjudicated. And that was followed by an improvement in heart failure symptoms as assessed by New York Heart Class. Almost every patient New York 3 or 4. You can see that on the right side. And after 30 days, of course, it's not a controlled study, 74% of the patients with moderate or less symptoms concerning their heart failure. So that's very encouraging.
Perfect. And I think you even brought more data on a world experience in a real world setting.
Yeah, this is data from a couple of centers gathered together and brought forward by the Cologne group, and you can see they mirror the results we have seen in the TRI-REPAIR study and also in the TRIPENT study. Initially, almost every patient with severe or larger TR, and after the procedure, most of the patients, roughly 70% of the patients with moderate or less. And this, as a consequence of this, heart failure symptoms are reduced within 30 days, as you can see on the right side.
So overall, I think very intriguing results again. And now we move to the last topic of our interview, and we will focus now on complete replacement of the tricuspid valve. Ralph, would you like to comment on this movie and quickly explain the EVOQUE valve system to us?
Yes, with pleasure. You see here that we have a transfemoral transvenous system with a 28 French delivery system. So very important, this is only a venous puncture. We use a safari wire, as you can see here, into the right ventricle, which is deployed by a steerable sheath. We implant then a valve with 9 anchors simultaneously into the cords and leaflets of the tricuspid valve, and have an added sealing with the outer stent to the annulus of the tricuspid valve. The inner valve is a normal tissue valve, as we know it from TAVR, but a very specialized soft external second stent that adapts to the contraction of the tricuspid valve. And this is done here under fluoroscopic and 3-dimensional and MPR echo guidance. So very interesting new concept. And perhaps we can see the first results in the next slide. So here we can see the first data of the TRISCEND study that analyzed, after the compassionate use experience, the efficacy of the EVOQUE valve to reduce TR severity with a core lab adjudication. As you can see, the grade severe, massive, and torrential, so very severe graduations were present at this baseline, and they could be reduced in 98% of the cases to non-trace or mild, which is typical for a transcatheter replacement system and superior to tricuspid TEER. On the right-hand side, you can see the performance of the valve after implantation, and please note that there is no transvalvular nor a paravalvular leakage in this valve implant.
So I think from this point of view, I would like to summarize. I think we have seen 3 upcoming new developing technologies from Edwards Lifesciences that allows us to have with very good clinical results to treat tricuspid valve disease. And since we're running out of time, I would like to thank again Professor von Bardeleben and Professor Nickernick for guiding us through these new technologies, and thank also Edwards for putting together this type of session and developing these new technologies for percutaneous tricuspid valve repair. Thanks, and have a successful EuroPCR 2021.